This voice note is an introduction to chronic constipation in an adult. Acute or transient constipation can be due to changes in diet, travel, or stress. And secondary constipation can result from drug treatment, neurological or metabolic conditions, or a colon cancer. Chronic constipation is either primary, which is also termed as functional or idiopathic, or it can be secondary due to other conditions. In general practice, we consider the possibility of a patient having constipation if they report having less than 3 bowel movements per week for more than a month. We use the Rome 4 criteria to diagnose chronic idiopathic constipation. These criteria state that you need to have at least 2 of the following factors before making the diagnosis of chronic constipation. The factors are straining during more than 25% of defecation attempts, having lumpy or hard stools for more than 25% of defecations, and lumpy or hard stools are classified as a Bristol stool form scale 1 or 2, a sensation of incomplete evacuation for more than 25% of defecations, a sensation of anorectal obstruction or blockage for more than 25% of defecations. Manual maneuvers are required to facilitate more than 25% of defecations, for example, digital evacuation and support of the pelvic floor. A patient reports fewer than 3 spontaneous bowel movements per week, and loose stools are rarely present without the use of laxatives. Some common causes of secondary constipation include metabolic, which would be hypothyroidism, hypercalcemia, hypokalemia, and uremia. There can be mechanical obstruction with colorectal cancer, rectoceles, rectal prolapse, anal fissures, and even megacolon. Psychiatric conditions, especially a major depressive disorder, myopathies induced by diabetic neuropathy, spinal cord injuries, cerebrovascular disease, and chronic immobility is also associated with the development of constipation. There are subtypes of chronic constipation, and physiological tests are required to differentiate these different types. These tests include colonic transit assessments, anorectal manometry, and balloon expulsion tests, which can facilitate the stratification of patients with different constipation subtypes. I'm going to discuss 3 of them quickly. Slow transit constipation is characterized by prolonged colonic transit in the absence of pelvic floor dysfunction. This subtype of constipation can be identified using either the radiological opaque marker test or wireless motility capsule test, and is best treated with laxatives such as polyethylene glycol. Dyssynergenic defecation results from impaired coordination of the recto-anal and pelvic floor muscles, causing difficulty with defecation. The condition can be identified using anorectal manometry and the balloon expulsion test, and it is best managed using biofeedback therapy. An emerging subtype that is becoming common and which you must be aware of is opioid-induced constipation. Drugs such as naloxone have been approved for the treatment of this condition. Here follows an approach to an adult patient with chronic constipation. As always, we begin with a detailed history. The history must be with regards to bowel movements, duration of symptoms, stool frequency, stool consistency, difficult rectal evacuation, sense of incomplete evacuation, straining, sense of obstruction during defecation. The patient's stooling habits should also be investigated. Do they do digital evacuation of the rectum? Do they do vaginal digitation to empty the rectum? Is there digital support to the perineum? Do patients do an abdominal massage? Are there unsuccessful attempts at defecation? Is there abdominal pain associated with the defecation? And is there bloating? With regard to general history, always ask about previous treatment for constipation, especially if they're self-medicating. Ask about medical comorbidities and chronic medication use. Was there previous gastrointestinal or anorectal surgery, and the impact of social activities and quality of life by this constipation? Also obtain a brief dietary history, including fluid intake, and ask about exercise. Also ask about a history of physical abuse or underlying psychiatric disorders. With clinical examination, actively look for colorectal cancer red flags, and if present, this patient must be immediately referred for a colonoscopy. These red flags include a new onset of constipation over the age of 50 years old, rectal bleeding, unintentional loss of weight, a family history of colorectal cancer or inflammatory bowel disease, iron deficiency anemia, and an abdominal or rectal mass with examination. A general examination looking for signs of metabolic abnormalities, loss of weight should be undertaken. An abdominal examination should be performed to exclude an abdominal mass. Digital anorectal examination should be performed at rest to exclude anal and distal rectal tumors, look for pathology in the anal and perianal areas, especially fissures, and if this examination is normal, then perform a digital anorectal examination while the patient attempts to defecate to identify pelvic floor contraction abnormalities. If difficult evacuation is the main complaint, bimanual vaginal and rectal examinations should be performed in women to identify rectoceles. Patients reporting symptoms of rectal prolapse should sit on a commode and be asked to bear down for 2 minutes to identify a rectal prolapse. At this point, if there are no colorectal cancer alarm features and no secondary cause is suspected, treatment may be started. This will be the vast majority of patients with chronic constipation. However, if there are signs of a potential underlying metabolic disorder, a reasonable panel of tests include a full blood count looking for iron deficiency anemia, a glucose test looking for diabetes, thyroid function test looking for hypothyroidism, and urea and electrolytes, as well as serum calcium looking for those electrolyte abnormalities.
Treatment of chronic adult constipation. General principles of treatment include changes in lifestyle, such as an increased intake of dietary fiber, oral fluids, and more exercise. Stooling habit advice should be provided, and this includes trying to defecate within 2 hours of waking up, defecating after breakfast, where colon motility is its strongest for at least 30 minutes after a meal. Establish a routine, same time, same place. Heed nature's call immediately, do not deny it. And spend no more than 15 minutes on the toilet trying to pass stools. Osmotic or stimulant laxatives are only indicated if there are insufficient effects of lifestyle changes. These include agents such as lactulose, fibergel, sorbitol, and there are many more. If these fail and there are no alarm features for colorectal cancer or an underlying structural disorder, then second-line drugs such as prokinetics and secretory agents may be prescribed. These include drugs such as Dulcolax, Senocot, Soflax, etc. Avoid liquid paraffin. It causes anal seepage and anal irritation. If taken regularly, it may cause fat-soluble vitamin malabsorption.
Anorectal physiology tests and assessments of colonic rectal transit time are only indicated if medical treatment fails or if symptoms indicate severely obstructed defecation or an underlying structural disorder. Assessment includes colorectal transit time, anorectal physiology tests, and imaging of the rectum and pelvic floor. If diagnosed, these patients may require specialized treatment, with surgery being restricted to a very small minority of chronic constipation patients. These patients would have very severe symptoms which do not respond to conservative treatment, and they should be under the care of a qualified colorectal surgeon before these kinds of decisions are made.